Good evening, everyone. Yeah. Hello. Good evening, everyone. Is my voice clear? Hi. Good evening, everyone. So, is my voice clear to everyone? First of all, I would like to thank all of you, all the ones who have joined today for the session. And definitely, a lot of people requested us for this session because we had conducted this session in the past, and a lot of people were requesting us if we can have a session on vestibular rehab, if we can have a session on vestibular rehab. So because a lot of our physio colleagues and a lot of our people, from our fraternity requested for this session. So just on a simple request of all of you, this earlier was a paid session. It was a paid lecture which happened around 3 months back. But on the request, and just because of the fact that we wanted everybody to learn and everybody to have that experience from an international faculty, for that reason, we are doing this YouTube live today. And this is a pre-recorded session, but it is a very interesting session, and it's a power-packed 2-hour session. So I will definitely request all of you to definitely stay for the whole session. And we would definitely love to have all of you guys to attend this session, and let's hope all of you have a important and an interesting session which is going on. I would also request all of you to share that link with all of your friends, all of your colleagues who might be in other state, might be in other city, might be in other country, whatever it might be. But definitely I would just like all of you to share this session with everyone, because we were lucky enough to have an international faculty associate with us, and just for the purpose of knowledge sharing. And they wanted students in India to learn from their experiences, how they treat the patients, how they take care of things. So they did all this session for the Indian faculty. So now, without further ado, I would like to share the session. And thank you all of us for joining us today for this session. And let's have a powerful session ahead.
All right, so in this picture, you can see the anatomy of the vestibulocochlear system. So today we'll be focusing only on the vestibular piece, and it consists of utricle and saccule, or in other terms, we know them as otolith organ, and the 3 semicircular canals, namely posterior, lateral, and superior semicircular canals. So now, what does vestibular system actually do? Any takers? What are some functions of the vestibular system? And you can feel free to use the chat function to respond, because I'm trying to make this as interactive as possible. And it's a Saturday evening, so I don't want to put people to sleep.
Balance?
Absolutely. Yes. So maintaining postural control is definitely one of the functions. Yes. Balance, posture, coordination to some degrees. Absolutely. Yes. Those are some very good points. So now if we want to take all these functions and categorize them into 3 broad buckets of information. So first bucket that we can talk about is the gaze stability. The next bucket would be spatial orientation. That means telling us that where our body is in space. And third, of course, is the postural stability. That includes your equilibrium and righting reactions. So now, like any computer system, vestibular system has 3 primary units. That is your input device, your central processing unit, and your output device. So when we talk about the input device, here is what we have. We get inputs from the vestibular system, of course, the proprioceptive system, and the visual system. As we all know that these are important systems for maintaining postural control. So from here on, from this input, the information goes to the processing unit, which is your vestibular nuclear complex in the pontomedullary junction and the cerebellum. And there's a lot of information exchange between these two information centers. And from here on, once the information is processed, it goes to the motor neurons. And from motor neurons, it can go one of two ways. One, it can go to the eyes or to your postural muscles. And the fibers that go to the eyes, they're responsible for your extraocular movement. All right, so here is a pop-up quiz for you. So while you're traveling in an elevator going up or down, so which of the two systems is responsible for detecting motion? Is it the utricle or the saccule? Take your pick. Which one will it be? You can feel free to unmute yourselves and answer, or you can use the chat function. So as we can see, Mr. Simpson is going up in an elevator. Absolutely. So saccule is something. Saccule? Yes, absolutely. Fantastic. So saccule is the system that is responsible for detecting vertical linear motion, whereas utricle is something that is responsible for detecting horizontal motion. For example, if you're going on a bike ride on a straight road, at that point of time, the utricle is acting. On the other hand, semicircular canal, it is responsible for detecting angular motion. We know that. So now we have talked about the input devices, we have talked about the processing unit, and now let us look at the output devices. So output can primarily be categorized into three domains. First is your vestibular ocular reflex, and that will be one of the key focus points for today's discussion. Second bucket could be the vestibulo-colic reflex. That is something that is responsible for maintaining the head in an upright position. And the third is vestibulo-spinal reflex. So as the name suggests, inputs go from vestibular system to the spinal muscles to maintain an upright posture and equilibrium. So now let us talk a little bit about VOR. So VOR, what does it do? So VOR, what it does is it creates eye movements which are equal and opposite to the head movement in both horizontal and vertical direction. For example, if I want to turn my head to the left or to the right, and I want to keep looking at this computer screen, so my vestibular ocular reflex is something that is responsible for my ability to do this. So if we go a little deeper into this, the VOR, it helps us to stabilize the image that we want to see on the fovea during rapid head movements, and thereby helps to maintain gaze stability. So now, since we know now what the function of the VOR is, what may happen if there is a problem with the VOR? Any thoughts on that, folks? What does everybody think? What might happen if we have an issue with the VOR?
A sense of imbalance during rapid visuals passing, for example, fast trains passing or fast cars moving.
Mm-hmm. Absolutely, yes. So we may have a sense of impaired balance or postural control, and we will have trouble focusing our gaze while we move fast. So now, why does that happen? Why do we have difficulty in focusing or maintaining our gaze. That is because the eyes move less than what is required. So there's a disbalance. So when the eyes don't move appropriately, there is a difficulty in keeping the image focused on the fovea, and therefore we need to have a corrective saccade. So somebody quoted the example of a moving train, and I think that's a great example. So when the train starts to move slow, we are still able to keep our focus on the trees outside. But when the train starts moving fast, so the VOR is not functioning to the optimal level, and that is why we have difficulty keeping that image of tree onto our fovea, and that is why we have blurry image. So when the retinal slippage occurs, there is a decrease in visual acuity. Great, great. Okay. Now, another thing about VOR that we should know is nothing but the ability of the VOR to produce an eye movement to stabilize vision, and it can be defined as ratio of eye movement to the head movement. So in ideal conditions, the eye movement should be equal or very close to the amount of head movement. So therefore, this normal gain ratio is usually around 1. So if we see a decrease in the overall gain, we can suspect that the patient is having bilateral vestibular involvement. The last key concept that we'll talk about is the push-pull mechanism. So as we now know that semicircular canals are something that exist in pairs. Increase of my right semicircular canal, and there will be a decreased firing of my left semicircular canal, so that the inputs are balanced. So usually the firing rate is about 70 to 100 spikes at rest. So say if I move my head towards the right, my right side semicircular canal will fire at 120 spikes, for example. So to compensate for that, my left semicircular canal would fire at 80 spikes per minute to keep the balance. So the advantage is that if the disease, it ends up damaging one semicircular canal, the counterpart is still intact and the vestibular system can still receive information from the contralateral semicircular canal. And the system has such a tremendous capacity to compensate that our body will keep adapting till the system has reached a threshold and cannot compensate any further. And that's when you start seeing problems. And you will notice that patients who come to you with vestibular problems, they would not want to turn their head in the affected direction. So some key takeaway points from this section is utricle is responsible for detecting horizontal motion. Saccule is responsible for detecting vertical motion, and semicircular canals are responsible for detecting angular motion. And we now know the nuances of VOR, and it helps us with gaze stability and visual acuity. All right, so I see somebody's having audio issues. Is anybody else having audio issues? So, Sonia, I think you might want to check your audio one more time. And if you still have trouble, I would say turn off the video. So that kind of improves the connectivity. So try that and see if that works. Okay, great. Fantastic. So now the next section that we'll look into is some pathology, signs, and symptoms. So here are some conditions that may affect the functioning of vestibular system. So if you have lesions in the vestibular end organ or the vestibular nerve terminals, if there are lesions in vestibular ganglia within the auditory canal, if you have a tumor at the cerebellopontine angle, so that tumor, what that would do is it would compress on the vestibular nucleus that is located in the pontomedullary junction. any lesion that involves brainstem or cerebellum, or any lesions involving damage to vestibular projections from the vestibular nucleus to the cerebral cortex. So now, some signs and symptoms. We all know that vertigo, dizziness, disequilibrium, and nystagmus, these are some very common signs that we look for in a patient with vestibular disorder. So now, vertigo, it is very important for us to differentiate between vertigo and dizziness, and we'll talk a little bit more about that in a moment. But before that, let's quickly look at some causes of vertigo and why that is important for us to identify if it is peripheral or central cause. Any takers on that? Thoughts? Why do we feel it's important for us as physios to know this distinction? Why do we want to know that, okay, is the patient having BPPV, or we have some brainstem related injuries, or the patient is having migraine? How will that impact our ability to work with this patient? Please feel free to share your thoughts. Any takers? All right, we have some. Yes.
Prognosis will be different.
Yes, so these are some good points. So knowing if the patient is having a peripheral disorder or a central disorder will further help us channel our direction in terms of treatment and referral to other healthcare providers, because there are some things in which PT is not going to help and some things PT can very much help with. So we really need to identify to establish a good course of action so that we save time, resources for both us and the patients, and have a better chance of prognosis, because, and I'm sure everybody experiences this in daily life, that there are a lot of delays in diagnosing and in treating, and that has a major impact on the prognosis. So knowing that distinction very early on, it is very, very important. So now, let us talk about how do we approach a patient who has vestibular dysfunction. So now, let's take a look at a case. Let's talk about Debbie's case here. So I'll read out the case. So Debbie is a 49-year-old female who's referred to PT by a neurologist with a medical diagnosis of vertigo/dizziness on May 2018. So Debbie reports a 2-year history of vertigo. She says that she delayed seeking medical care because she was caring for her husband. She's the only caregiver. And in August 2017, the investigations revealed that Debbie had 2 brain aneurysms. So the larger aneurysm was repaired in December 2017, and the smaller one remained stable. So now Debbie had a follow-up with a neurologist, and she's now cleared to resume PT. So she presents to you with a complaint of dizziness or vertigo. We don't know that yet. She reports of blurring of vision with head movement, and she reports that her balance is off. And due to these reasons, she is not able to go to work. And Debbie here works as a librarian. So she needs to lift and carry books. She needs to look up and down, turn her head around, so on and so forth. So now my question to you is, what more would you want to ask Debbie? What are some questions that we can think about? If Debbie is your patient, what will you ask her further? What are some follow-up questions?
possibly to ask about what sort of movements or what sort of environment causes that instability or imbalance that she feels?
Absolutely, yes. So what are some precipitating factors or the aggravating factors for her symptoms? Yes, any positional variation? Absolutely, yes. Any head movement? Absolutely. So we can get more specifics on that. Linear or horizontal movements? Yes. So I can see that we are talking about specificity of movement. Yes, absolutely. And that's one very important question to be asked. Absolutely. Anything else we would like to ask? Apart from head movements and the precipitating activities, what else can we talk about? Yes, if it is unilateral or bilateral. Yes, very important question. Absolutely. Anything else? Nystagmus is something that patient may not be able to tell us, and that is something that we'll have to observe. But nystagmus is a very, very important clinical find. Yes, and we will talk about nystagmus momentarily. Absolutely. Yes, some other sensations like vomiting, so on and so forth. Absolutely. Any headaches? Perfect. So I think those are some very good points, everybody. Well done. Great work. So now let us take over a few more points. Oh, yes, I see that if she's spinning or feeling blurred. Yes, that's very important. Let's talk about that. So now, we'd want to ask if the onset of Debbie's symptom is acute or chronic. So it is a possibility that Debbie may have some dizziness from her aneurysm, but she may have a recent episode that may have triggered her condition. So making that distinction would be something we would want to know. Nature of symptoms, whether the symptoms are continuous or episodic, as you folks highlighted. That is it motion provoked? Is it migraine related? Or is it just spontaneous? What's going on over there? And very important question. When we start discussing dizziness with our patient, so let us ensure that we tell the patient very explicitly to describe the feeling without using the word dizzy, because dizzy, folks, is a very generic term. And there are many things that can be described by patients as dizzy. So let us try and move away from this term dizzy and see what the patient is actually feeling. So if the patient tells you that, okay, there is a sensation of room spinning, or I'm spinning in a room, so that is a sign that the patient may have true vertigo. And it is common with peripheral vestibular disorders. That includes BPPV. Wonderful. If the patient feels lightheaded, then we may want to look in the direction of any cardiac causes, any orthostatic hypotension, any chance that the patient is having a transient ischemic attack. Because as we now know that for stroke patients, there are multiple transient ischemic attacks many of the times before the patient has an actual stroke. Another important thing is checking patients' medications. And let me share my own personal story with you. So this is a very rookie mistake that I did in the beginning of my career. So I was working with a patient at a nursing home, and this individual, he was about 65, 70 years old. He was on dialysis. And every time we brought him to physio, we tried to perform gait training, sit to stand transitions. He would just get so described. He would describe that I'm so dizzy. And he used to get lightheaded and he used to pass out. So we tried multiple things with him. We tried doing all the testings, maneuvers, but nothing stood out. So ultimately what happened was we went back to the charts. And what we found that this individual was on 3 different antihypertensive medications. And plus this individual was on dialysis. So there was a lot of fluid imbalance, that is one thing, and 3 antihypertensives were dropping his blood pressure so much that he could not bear standing position for more than 10 seconds. So when we worked on that, we had a conversation with the doctor and the medications were adjusted. And then his symptoms improved drastically. So that is why it is very important to know if the patient is actually having a spinning sensation or the patient is feeling lightheaded. If the patient tells you that they're feeling heavy-headed, then it could be a migraine-related dizziness or there could be a central cause. If the patient says floating or rocking, if the patient says that, oh, I still feel like I'm on a ship or I'm in the train, and I still feel that I'm rocking, I'm moving. And many of us may have experienced this, that when we get off the train after a very long journey, we still feel for a few minutes that we're still in the train and we're still moving. So, but if this condition persists, if this stays on, so that is something that we know as mal de débarquement syndrome. That is a persistent feeling of floating or rocking. And this sensation can also be associated with anxiety or depression. If the patient complains of motion sensitivity, it could be related to migraine, and we may need to do further VOR testing. Oscillopsia, that means if the patient tells you that whatever is in front of me, it appears to me that it is bouncing. So that indicates bilateral peripheral vestibular disorders. And lastly, if the patient talks about having disequilibrium and not spinning per se, that can be a result of many peripheral, vestibular, and central pathologies, and we will need to do more testing. So now you can see that having that description of feeling of dizziness in other words, it is so important to direct us towards the line of further investigation. The next piece, this is very, very helpful, especially when diagnosing peripheral versus central disorders. Duration of symptoms. So if the duration lasts for say seconds only, then we can think in the direction that patient may have a BPPV, or the patient may have orthostatic hypotension, because these are the conditions where the symptoms are very short lasting. But if the symptoms are lasting for say a few minutes, then we may think in the direction of migraines, transient ischemic attack, or panic attacks. If the symptoms, they are more persistent and they're lasting for hours, we may look in the direction of migraine or Meniere's disease. If the symptoms are lasting for days and they're not getting better, the patient may be undergoing initial vestibular crisis or may have a central pathology that is going on. And if the patient is telling you that, oh, I'm dizzy all the time, I'm dizzy all the time, there's nothing that makes it better, there's nothing that makes it worse. So that can tell us that either this patient may have a bilateral vestibular impairment or there is a central pathology going on. So another interesting thing related to constant dizziness. So patients with cancer who are usually on drugs, and one of the drugs is gentamicin. So a long-term side effect of gentamicin is constant dizziness. So you'd want to check the medical records of this patient for gentamicin use if the patient has a history of cancer. So that's another thing that we'd want to look into. So apart from this, we would want to know the frequency of symptoms, whether the symptoms are occurring daily, weekly, or monthly. And we already talked about precipitating factors, specific head motions. Say if the patient tells you, oh, I get dizzy only when I lay down on my bed on left side and when I get up from my right side. So you may think in the direction of BPPV, absolutely. But if the patient tells you that my symptoms are precipitated by bright lights, sounds, or visual motion, then we may think in the direction of migraine. So along with this, it is important to obtain a history on falls, the frequency of falls and whether the falls were injurious or not. And what's the impact of dizziness on their function. Sure, please go ahead.
So I think that was by mistake.
Okay. All right, so the next piece that we would want to look for is the associated symptoms. So this is very important, folks. So if the patient complains of hearing loss, so remember in BPPV, there will not be an association of hearing loss. The patient with BPPV may not have hearing loss. So if you have a patient that tells you that I'm having hearing loss, so you may expect any of these: Meniere's disease, labyrinthitis, or acoustic neuroma. If the patient tells you a complaint of tinnitus, we can think in the same direction again. If the patient tells you that, oh, I feel like my ears are full, then we may think in terms of superior semicircular canal dehiscence. That means there is a rupture of superior semicircular canals and the debris is floating around in the inner ear. If the patient is complaining of photophobia, phonophobia, we can think in the direction of dehiscence or migraines. So let us talk now about the red flags. This is something that we should be very, very careful about, that if we come across one or more of these, either during our history or our examination, we must refer this patient to the physician or a neurologist for further evaluation. So if the patient has persistent worsening of vertigo or disequilibrium, person complains of severe headaches, severe diplopia, dysarthria, dysphagia, any cerebellar signs, ataxia, for example, or any asymmetrical muscle weakness that may mimic sign of a stroke or a transient ischemic attack. Or if you come across any evidence that makes you think in the direction, oh, this person may have a spinal instability. So please refer these patients to the physician or other healthcare providers. So now, we talked to Debbie further. We asked her all these questions, okay? So now what we found that Debbie's recent complaints were a sudden onset, and the dizziness lasted anywhere around 15 to 20 seconds at a frequency of about 15 episodes per day. So about 10 to 15 times she had brief episodes of dizziness that lasted anywhere between 15 to 20 seconds. And she reported a vertigo, that is room spinning sensation. And she reported that she loses balance with any rapid movement. And these are some activity examples that she has trouble with. So what does that make us think? What probably is going on with Debbie? Most likely, based on your history, we have not yet touched the patient. Just with a history, what can we think? What may be going on with Debbie? Absolutely. So we can think in the direction of BPPV because probably not central. The symptoms are very much mimicking the BPPV. Absolutely. Great. Well done, everybody. Great job. Okay. So now, what would you want to include in the systems review? That means, what are some other things apart from vestibular system that you would like to look in for Debbie? What would you like to do? Apart from vestibular exam, any other systems you would like to look into?
It may involve.
I'm sorry, Tushar, can you say that again?
It might be an involvement of, low counts of your hemoglobin. Another thing is patient may have may have to check his or her specs number as well, because at times when there is a a frequency that patient may have an alteration in his or her specs numbers, they may feel giddiness. And one more is if the patient is having severe common cough and cold, and it's they are having a higher frequency for the same, then due to accumulation of mucus in their top of their head near the sinus, they may have this dizziness. And one more thing is cervical spine, upper cervical spine.
Absolutely. Great. So I think those are some really, really good points. So if you have the records available, you can take a look at the hemoglobin levels. Yes, absolutely. If the patient is anemic, absolutely, you can take a look at that. But for Debbie, do we want to do that? And I love the idea of doing the cervical spine. Absolutely, because we know that dizziness is something that can originate from cervical spine or from the vestibular system or both. Absolutely, yes, fantastic. All right, so cervical spine, we would look for range of motion, any tenderness, pain, so on and so forth. Absolutely, I agree. Anything else apart from BP and cervical spine examination? Anything else we would like to look at? History, absolutely, talked about that. So a few more things, folks, can include an assessment of her cognition. If there is a cognitive decline, how is she doing in that department? It is very important to do that. Pain assessment. Since we have talked about evaluating cervical spine, pain assessment is of prime importance, especially if the patient comes to you with a history of trauma, fall, or say a sport-related concussion. It's very, very important to evaluate pain. A generalized sensory examination, including proprioceptive, light touch, pain, and vibration, and so on. So would we like to do any cranial nerve testing here, folks? And if so, what cranial nerves do we want to assess, knowing what we know so far? Absolutely. We would want to assess the oculomotor function. Yes. We'd want to assess the vestibulocochlear nerve. Absolutely. So we would look at the cranial nerve assessment of cranial nerve 2, that is your optic, 3, 4, 6. These are primarily responsible for our extraocular movements, and the 7th, facial cranial nerve, given its proximity to the vestibular nerve nucleus in the pontomedullary junction. So apart from cranial nerve examination, we would do positional testing, vestibular tests, and we would do additional testing for balance, gait, and self-reported questionnaires. Wonderful. All right, so now we have talked about history, what is important, the onset, acute or chronic, versus duration of symptoms. Are they lasting for seconds, minutes, hours, or days? We want to know that. And we want to know the description, exact description of that feeling of dizziness. Wonderful. All right. So now clinical testing. And someone brought up vertebro-basilar insufficiency or VBI testing. Before we even touch the patient for vestibular testing, it is something important that we rule out vertebro-basilar insufficiency. So let's all of us do it together. So let's all sit upright. I mean, I cannot see all of you, but I'm assuming that you are following the test with me. So let's all sit upright, lean upper trunk a little bit forward, and then let us turn the head to 45 degrees and extend and hold for the symptoms to appear. So if the patient is symptomatic in this position, we would stop the session and send this patient back to the doctor for further testing. So ruling out VBI is a rule of thumb before we even begin thinking about doing other positional testings. So Hallpike Dix, I think most of us may be familiar with the Hallpike Dix maneuver. This is a gold standard for diagnosing posterior semicircular canal, BPPV. Some contraindications to Hallpike Dix include severe rheumatoid arthritis, any recent surgery to the neck or trauma, any VBI or Arnold-Chiari malformation. Absolutely. So usually the testing is done using infrared goggles to look for nystagmus. So now let us take a look at a video on how the Hallpike Dix test is performed. So can everybody see the video displayed? Give me a yes or no, please.
Yes, sir.
Okay, great. Everybody can see it. Fantastic. Okay, so now the therapist is testing for the left Hallpike Dix position. So as you can see, the head of this patient is rotated 45 degrees to the left. Now let's see what happens. So there's a quick movement to supine, and the therapist keeps the head in extension. And as you can see, there is a nystagmus that is persisting for a very short time, and it is slowly stopping now. Let's take a look at the nystagmus one more time. Great. All right. So, with that being said, you notice that in this test, the therapist is or was standing behind the patient. So what do you think we can do differently? And what can be some problems if the therapist stands behind the patient? What might happen? Thoughts on that? Okay, I see something up here. Any opinions? Can we do this test a bit differently rather than standing behind the patient? Yes, it may be likely that we may miss the nystagmus if we stand behind the patient. Yes, that is one thing. Absolutely, I agree. What else? What else might happen? So another thing, oh, I see one more popping up here. Yes, okay, therapist can stand in front. So why is that important? Is that I'm sure you must have noticed the patients who come with BPPV or dizziness, they are very scared of the movement and they tend to close their eyes. So one thing is very important, that we need to secure the patient so the patient is not fearful of losing balance, and we have the control of patient's body. So it is very important that we stand in front of the patient so the patient has something to look at. You can ask the patient to focus on your nose or focus on your face while you're performing this test. So that way we are ensuring that the patient is making the best possible attempt to keep his or her eyes open. That is number one. Number two, if the patient feels very scared of being moved, so they can hold on to your forearms while you help them go to the supine lying position. So that is a better position to perform the Hallpike Dix instead of standing behind the patient. And especially if you're meeting the patient for the first time, you don't know the patient well and how well the patient is going to respond. So I would suggest staying right in front of this patient. So now once you do this test, there will be an exaggeration of symptoms. Absolutely, you'll be able to see the nystagmus and symptoms will be reproduced. Okay, so we have a question that can we do this test if the patient is having symptoms? Yes. Answer to that is yes, we can do. Okay. Yes, we can do the test when the patient is having symptoms. Absolutely. Dr. Reza, we would come back to your question towards the end of discussion because I think this will stimulate a lot more clinical reasoning and discussion. So that's a very good question. Thank you for putting that up, and please bring it back at the end of the discussion today. We'll be very happy to discuss that. All right. So now, when we talk about nystagmus, we know that nystagmus has a slow phase and a fast compensatory phase, which is saccadic in nature. So now, when we name nystagmus, and personally, I struggled a lot while identifying and naming the nystagmus. So now, an important thing to remember is that nystagmus is always named for the quick phase. So if you're observing nystagmus and you see that the fast movement is towards the right, so it is a right-sided nystagmus. And the fast phase is always towards the normal side. So that means if you have the fast component to the right, you have a problem going on with the left side. So that is one thing. Another thing is, it happened to me a lot that, okay, who's right? My right side or patient's right side? Which right side is the fast phase? So always make sure that it is in reference to the patient's right side or left side. So, for example, a right beating nystagmus means that quick phase is beating to the patient's right side. All right, so let's take a look at a couple of examples for nystagmus. And nystagmus can also be elicited using caloric testing, rotary chair, or optokinetic assessments. So let's take a look at a couple of more examples for nystagmus.
Now I'm going to put on a light and look at the light.
All right. So is everybody able to kind of see clearly the fast and the slow phase of nystagmus? All right, let's take a look at one more example. So usually it is kind of difficult to see the nystagmus without the Frenzel lenses or the goggles because of simple reason that patients will close their eye because they get so symptomatic. So that is why we use the infrared or Frenzel's goggles, but with a clear instruction to the patient about keeping the eyes open, it is possible that we will be able to see nystagmus to a certain degree. All right, so now this therapist is trying to perform the Hallpike Dix maneuver, and you will see how the nystagmus comes in immediately. So it's testing. So what side is being tested here, right side or the left side? What do we think? The patient's head is rotated towards the right. Which side are we testing? Absolutely, we are testing the right side. Great, wonderful. All right, so let's see what happens. So look at the duration that nystagmus will calm down in a few seconds, and it is beating towards the left side. All right. Wonderful. Okay. All right, so now I think it's close to an hour. So what we'll do is we will take a quick break for about 10 minutes. And when we come back, we will talk further about nystagmus, and then we'll move on to the vestibular ocular testing. So let's take a 10-minute break and we'll reconvene then. All right, everybody. All right, so we are back. And while we were on break, we had another question that disequilibrium and unsteadiness, they also occur in central lesions. How do we differentiate this from a peripheral problem? So what I would recommend doing in this condition is digging a little bit more into the history and asking the patient if the dizziness and or the disequilibrium or unsteadiness, is it constant or does it happen episodically? And if so, how long are the episodes? Because mostly in central lesions, these problems are more or less constant. They may go up and down, but there may not be a time that the patient is completely relieved of the symptoms. So it is a possibility. And then I would also ask for other associated symptoms. For example, if there is discoordination, is the patient dropping the things? Is the patient having difficulty in reaching, grabbing an object, say maybe having difficulty feeding themselves, dressing themselves? So if that is something that is going on, that will point me in the direction of more central involvement, and I would like to do more cerebellar testing. So that's an example of how we can differentiate between the peripheral causes and central causes of disequilibrium and unsteadiness. Any follow-up questions on that? All right, wonderful. Okay, so let's go ahead and move forward to further discussion on the nystagmus. All right, so spontaneous nystagmus, it can occur after a peripheral vestibular insult, and it usually disappears within a few days to weeks as the body starts compensating. So now what we need to look for in a nystagmus is that if it is upbeating, downbeating, and does it have a torsional component to it. So now torsion is nothing but a clockwise or a counterclockwise movement of the eyes, and it is commonly seen in posterior canal BPPV with an addition of upbeating component. So this but it seems we are having some technical issues with the meeting, so we'll resume in a moment.
Hello. So we can hear you now. Can we start it again?
Great.
Yeah.
Yeah, definitely.
Thank
Let's
you.
start it again. So I'm going to share my screen again. And we will take a look at a couple of examples from upbeat and downbeat nystagmus. So let's take a look at the upbeat first. And notice for the torsion component here. All right, here's an upbeat nystagmus. All right. So here, what I would want you to focus on that, along with that upbeat that you see, say, let's say that this is the eyeball, and say if this is the upbeat nystagmus, you'll also see a rotation or the torsion component of it, like so, in clockwise or anti-clockwise direction. So what you will see is an upward movement with a clockwise or anti-clockwise movement. And this is best seen using the infrared goggles. All right, so let's see if we can take a look at the downbeating nystagmus. Yeah, and this is an example of a downbeating nystagmus. So as you can see, the movement here is downbeating, and it does have a strong nystagmus. So now, another important thing that when we talk about BPPV, so we all know that the crystals, they are dislodged and they are not where they're supposed to be. So where are they? So there can be two things that happen here. Either they can float around in the semicircular canal. If that is the case, we call it canalithiasis. Or if they are not floating in the canal and they're stuck on the hair cells, that's what we call a cupulolithiasis. So how do we differentiate that, whether the patient is having canalithiasis or cupulolithiasis? In canalithiasis, the nystagmus lasts usually less than 60 seconds, but in cupulolithiasis, it can last more than 60 seconds and maybe sometimes more than 2 minutes. So observe for the time it takes for the nystagmus to disappear. Because in cupulolithiasis, the crystal is stuck. So it is, say, if this is your hair cells and here's a crystal stuck, so it will keep the hair cells down due to its weight for a longer time. And that's why the body will take longer to compensate and stop that nystagmus. So look for the duration of symptoms that will tell you if the crystals are in the canal or in the cupula. Sure, so we can talk about that again. So in BPPV, we know that the crystals, they are not where they're supposed to be. So two things can happen. Either the crystals can float up freely in the semicircular canals. If that is the case, we know it as canalithiasis, and the duration of nystagmus is less than 60 seconds. But if you see that it is not going away in 60 seconds and it is lasting maybe up to 2 minutes or even more, then you may start thinking in the direction of cupulolithiasis. That means the crystals are stuck to the hair cells and they are pulling the hair cells down and not letting the body compensate as quickly as it happens in canalithiasis. So because this distinction is important, folks, because that will help us in choosing that, okay, do we just have to place the crystals back where they came from? Or do we first need to dislodge the crystals, shake them out, because they're stuck in cupulolithiasis? So do we need to shake them out, or we just need to put them in place? So that distinction is very important in directing our course of treatment. So now, let us talk about the beats. So upbeating nystagmus most likely indicates a posterior canal involvement, and a downbeating nystagmus most likely tells us that anterior canal is involved. So here are a few examples. You can feel free to spend a moment with them. So if there is a right All right, so we'll come back to the cupulolithiasis versus canalithiasis in a moment as we sum up. So we'll go over that one more time. Absolutely, we can do that. So now, just remember that if the nystagmus is upbeating, so you can remember this as up, UP, upbeating, posterior canal, and downbeating leaves you with anterior canal. So always remember the abbreviation up. So now, we'll talk about the treatment of BPPV. Say, for example, if we find that, okay, we have a posterior canal involvement, while the patient is in that position, we will fix that right then and there. So we will perform an Apley's or canalith repositioning maneuver. So this would be the case if we have canalithiasis, which means that the crystals, they are floating in the semicircular canals and they just need to be repositioned. They do not need to be dislodged. That is when we would do the canalith repositioning maneuver or Apley's maneuver. So let's take a look at what Apley's maneuver looks like. Oops. There we go. All right, so let's take a look at Apley's maneuver.
There are a number of treatments and a number of maneuvers to treat benign paroxysmal positional vertigo. However, the Apley maneuver is the most well established, and it's the test that's been proven to be successful in this condition. The first part of the Apley maneuver is essentially performing the Dix-Hallpike maneuver. Once the head has been extended, I always make sure that if the patient is feeling dizzy or I see some nystagmus, I wait for this to completely resolve before continuing to perform the next stage of the maneuver. The head is turned 90 degrees towards the opposite shoulder. This means that the head now lies 45 degrees relative to the vertical plane. You can relax your arms now. What I'd like you to do in your own time is to roll onto your left-hand side and just let me support your head. Whilst the patient is turning, the head is rotated a further 90 degrees in the same direction. Finally, the patient is asked to sit up with their legs over the side of the couch. During this maneuver, I like to take control of the head so that I can position it as I would like it to be. At the end of the maneuver, I ask the patient to finish so that their chin is sitting nicely on their chest.
All right. All right, so that was the Apley's maneuver. So what is important to remember, we all saw that, say if we were tested the right side and we found it positive, we stay in that position till the symptoms subside, and then we slowly turn the head 90 degrees towards the left side in this case. And then we have the patient slowly sit up. So what is a common mistake that happens during this maneuver, folks, is that in this video also, if you noticed that the therapist lost a little bit of cervical spine extension while rotating the head. So it is important that we maintain that 20 to 30 degrees of cervical spine extension while rotating the patient's head. So don't lose that grip. And once the patient is sitting up, what used to happen previously is that the patient was asked to wear a cervical collar for a few days till the time patient came back for a follow-up visit. So now that is something that does not happen anymore because it has been found that immobilizing patient's neck, it is not useful at all in recovery, and it is now out of practice. So the patient can feel free to move the neck around, absolutely. The only thing that I would want you to consider instructing the patient about is that not doing a sudden neck extension. For example, ladies, when you try to fix your hair into a ponytail, what do we usually do? You bend the neck forward and just do a quick sudden cervical spine extension. So that is something that is not recommended right after an Epley's maneuver is done. So now a question may be asked that, oh, my patient is very old and patient cannot tolerate supine position. What do we do? So there is a way that we can still do the Epley's maneuver. We can use the side lying position for that. And this is very helpful for patients who are not able to assume supine lying positions for multiple reasons. So let's take a look at that. So we'll see how this is modified. All right, so he's going to talk for a little bit, and then we are starting. Rotated the neck to 45 degrees. And as you can see, the patient is now holding on to the therapist's arm for security. That's a relatively quick movement. So stay there till the symptoms go away. So the therapist is still waiting for the nystagmus to stop and symptoms to resolve. And while the therapist is staying there, then now we turn slowly to the other side, and then stay there till the symptoms resolve, and then slowly we would come up. And then we move on to the sitting position slowly. All right, so we have a question that if we cannot see nystagmus, then shall we ask for dizziness? Absolutely. Yes, we would ask for dizziness, and most of the time, folks, the patients will tell you, oh, I'm super dizzy. And I would highly recommend keeping a dustbin nearby because many a times patients would vomit. So you will see an acute exacerbation of symptoms, even though if you're not able to see the nystagmus. So you will see other symptoms like throwing up or increased dizziness. So definitely we can ask for dizziness. Absolutely. All right. Okay. So now we talked about the canalith repositioning technique. So we looked into canalithiasis. That means the crystals were floating in the semicircular canals. We resolved that issue. The next issue that we talked about, what if the crystals are stuck and they are stuck to the cupula? So here we need to liberate the crystals from the cupula, and we use something called as Simont or liberatory maneuver for that. So let's see what that looks like. Oh, there we are. Okay, here we go.
To perform the Simont maneuver, have your patient sit in the middle of the treatment bench with the head turned away from the affected right side. Then quickly bring the patient into side-lying position toward the affected side with the head turned up. An nystagmus will occur shortly after arriving at the side-lying position, and a patient will probably experience vertigo. Keep the patient in this position until at least 20 seconds after all nystagmus has ceased. Some even recommend up to 1 or 2 minutes. Then quickly move the patient back up with the same head position and through the sitting position so that he is in the opposite lying position with the head facing down. Again, keep the patient in this position for about 30 seconds. Again, some authors report to hold this position for even 2 to 10 minutes. At last, slowly bring the patient back up into sitting position. A meta-analysis.
All right. So we now looked at how can we liberate the crystals if they are stuck to the cupula. So as you can see, there's a quick transition from one side line to another. And it is important that we instruct the patient that, okay, this movement is going to be quick, and you can also give the patient cues. Okay, we are going to move on 3. 1, 2, 3. Because many times what happens is if the patient doesn't know that what you're going to do, it is very likely that patient would fight you and not let you complete that movement smoothly. And it is very important if we want to have that liberation of crystals that this movement happens very quickly and very smoothly. Therefore, explicit instructions to the patient is really, really important here. All right, so now that was about the posterior canal. We looked at the Epley's maneuver for canalithiasis, and we looked at Simmons maneuver for the liberation. Absolutely. And as far as the instructions to the patient goes, so it really depends on how your patients respond to you. So what I would usually do is I would go over the instructions first, and then I would also brief the patient. Okay, we are going to lay on your right side. 1, 2, 3. So that way patient has more cues and patient can remember to cooperate, because we need to understand that patient is also having symptoms. And should there be only 1 repetition, I can go up to 2 repetitions, 2 to 3 repetitions, and that is usually acceptable if the patient's symptoms are resolving. So we can go up till 2 to 3 repetitions, but I will not go more than that. All right, so that was about the posterior canal. The next piece we want to talk about is the horizontal canal. So this horizontal canal, it is examined using the roll test. So Hallpike Dix is usually done for primarily posterior canal, and if you're suspecting horizontal canal involvement, we would also do a supine roll test. And many times it may happen that you see a combination of horizontal canal and your posterior canal. Anterior canal is actually very rare, and I have not seen a case yet of an anterior canal involvement. So usually it is the posterior canal or the horizontal canal. So let's see how we do the supine roll test.
The supine roll test assesses the horizontal semicircular canal for the presence of displaced otoconia that is causing vertigo. To begin, the patient lies in supine with their head in midline and pitched up 30 degrees. Maintaining this head position, the patient's head is turned to either side. In this position, the examiner will be looking for horizontal beating nystagmus. This is also performed on the opposite side.
All right, so you can see that for the horizontal canal, we start with the head rotated towards 45 degrees, and we look for nystagmus, and this is done bilaterally. So here you will observe, no, there is no extension here, absolutely. The head is kept in about 30 degrees of flexion to make sure that the horizontal canal is in alignment with the floor plane. So what we will want to observe here is whether the nystagmus is geotropic or apogeotropic. So let's focus on these two terminologies for a moment. So geotropic means that the nystagmus is beating towards the ground, and apogeotropic means the nystagmus is beating away from the ground. And this is something that can be slightly confusing. So what I would recommend remembering that if you see the nystagmus is towards the ground, or you see the geotropic nystagmus, the fast component is towards the ground, we can think about that the patient is having canalithiasis. And if you see the apogeotropic, that means if the fast component of nystagmus, it is going away from the ground, that may indicate that patient has a patient has cupulolithiasis. So towards the ground, canalithiasis, away from the ground, cupulolithiasis. And there are multiple ways Oh, that's a good question. The question here says that if there is no nystagmus but dizziness, how do we determine canalithiasis or cupulolithiasis? So in this case, I would recommend further testing on the cervical spine and other system examinations, because usually with the vestibular involvement, you will see nystagmus. If you have access to the Frenzel lenses or infrared goggles, I would highly recommend using that. But if you don't see any nystagmus even after using the infrared goggles, I would recommend looking for other causes of patient symptoms, and it is likely that patient may not have a peripheral vestibular involvement. There is something else going on. Yeah. So now, how do we treat this? We treat, one of the procedures that is most commonly used to treat horizontal canal is the barbecue roll maneuver. So this is what a barbecue roll maneuver would look like to us.
And then slowly lay down on your back. Roll onto your right side and wait for 30 seconds. While your head remains in contact with your pillow, slowly roll onto your back and again wait for 30 seconds. While your head remains in contact with the pillow, roll to your left side and wait for 30 seconds. Gently tuck your chin towards your chest, roll onto your stomach, propped on your elbows. Wait for 30 seconds. Then gently tuck your right elbow underneath your body, rolling back to your right side, keeping your head level, and wait for 30 seconds. From there, return to sitting at the edge of your bed slowly and keep your head level.
So as you can see that in this barbecue roll maneuver, you complete a 360-degree turn, and what is important is that you stay in that position till your symptoms go away. Even though the video says that, oh, you should stay there for 30 seconds, I would recommend staying as long as it takes for the patient's symptoms to reduce or subside. Then we move on with the next positional change. So I do have a question here about the geotropic and apogeotropic nystagmus. Absolutely, we can talk about that one more time. So what happens with the geotropic and apogeotropic nystagmus is that in geotropic nystagmus, you will see that the fast component is beating towards the ground. So if I have a right beating nystagmus, so my fast component will be towards the ground. So if I'm lying like this, so Fast component, if it is towards the ground, that means I have a geotropic nystagmus, and that indicates that the crystals are floating in the canal or the canalithiasis. Now, if you see that I'm in this position again and the fast component is moving away, it is going to the left, that will tell me that there is a chance that I have cupulolithiasis. So remember that. All right, so that was all about the BPPV. Those are some important things that you can take and start applying in your clinics. The next piece, the important piece that we would want to talk about is the oculomotor examination. And I'm sure we must have done this at some point. So first and foremost, we'll need to see if there is any spontaneous nystagmus. So while you're talking to the patient, just pay close attention to the eyes and see if they're moving. And if this nystagmus is resolved, if you ask the patient to say fixate on your nose, if that gets resolved or not. That is first thing we'll need to document. Another thing is ocular range of motion. That is the H test. It is the same thing that you do for your cranial nerve examination. So you will take a finger, or you can say take a sharp object or a brightly colored object and ask the patient to follow along. You test the range of motion of your eye muscles. You can do a quick H test. So while you're doing this H test, along with testing the range of motion of extraocular muscles, you are also looking at the smooth pursuits. Smooth pursuit is something that means the ability of the eyes to follow a moving target. If I'm able to follow a moving target smoothly. So what might happen is, say, let me see if I can get as close to the camera as I can. All right, so please excuse my funny looks here. So if I'm trying to follow this object and suddenly I feel that, oh, I need to refocus my eyes again. So if you see a saccadic pursuit, saccadic means quick shift from one point to the other point. So if I have 2 points of interest here, and I'll focus on my left finger, then I focus on my right finger. Left finger, right finger. So this shift from one target to the other, it is called as saccade. And if you see a saccade happening while you're doing a smooth pursuit test, that is something that is abnormal. That should not happen. That means there is a problem with VOR going on. The next thing that we would want to look into is gaze-evoked nystagmus. So we would take an object and we will take it to the extreme of patient's lateral visual field and we'll wait to see if there is any nystagmus. Usually there is a certain degree of nystagmus. Normally, you can see in a gaze-evoked nystagmus, but if it is persistent, that is something that is abnormal. And if it stays longer than, say, 15 to 30 seconds, it is usually an abnormal sign. The next thing we talked about was the saccades. We'll check for saccades. Another thing that we would want to do is the VOR cancellation. That means this is an indicator of any central, primarily cerebellar dysfunction. So here is what it will look like. So you start in this position where you have the patient sitting upright and the hands are clasped, and you ask the patient to focus his or her gaze on the thumbs. So what happens next?
All right, as a clinician.
So you ask the patient to maintain the focus on the thumbs as you move the entire upper trunk and head in one block. As you can see, there's no dissociation between head and trunk. It is moving as one block. So ideally, the patient should be able to maintain her focus on to her thumbs. But if she's not able to maintain this, that means we have a problem going on indicating cerebellar involvement. So that is the VOR cancellation test. All right. The next test we would talk about is the head thrust test. And the therapist here you can see is Dr. Amy York. She's one of my mentors from University of Michigan-Flint, and she's a pro at Vestibular. So let's take a look at what she has to say.
The head thrust test is a portion of the bedside oculomotor exam that tests the vestibular ocular reflex at high frequencies. It is important to do this test at a very high speed and have it be unpredictable. This test is useful when ENG and caloric testing are not available. The patient is sitting in room light, and the examiner stands in front of the patient and flexes the patient's head 20 to 30 degrees. The patient then is instructed to maintain visual fixation on the examiner's nose as their head is oscillated back and forth and then stops suddenly and unpredictably to one side. I will repeat the test again, and this time you will be able to see the patient's eyes. When her head was moved to the left, she was able to maintain visual fixation. The left side is negative. However, when her head was moved to the right, she was unable to maintain visual fixation on the target, and a corrective saccade needed to be made back toward that target. This indicates a positive head thrust test to the right, indicating a vestibular hypofunction on the right side.
So when we talk about the head thrust test, as you can see, that first thing she did was bring the head to a 30-degree of flexion. This is to make sure that the canals are aligned in a proper way. And then you start moving the head slowly, and it works best if you don't tell the patient when you're going to move fast, so that patient cannot trigger a compensation. So, and if the patient is wearing glasses, I'll take them off. So hold the head, bring it to 30 degrees of flexion, do few slow movements, and all of a sudden, a quick movement. And all this time, the patient is asked to focus on your nose. So you see if there is a corrective eye movement that the patient needs to make to bring his or her focus back on your nose. Yeah, so cogwheel is kind of another synonym, Vikrant, for the broken eye movement or saccade. So you'll see there is smooth movement for some time, then it breaks, then it's a smooth movement again. So that is what you know as cogwheel. That's another term. I understand that these are a lot of tests, but I think it is very important to do these tests if you are suspecting a oculomotor impairment. So I think this is the last test that we would do for the oculomotor stuff. So this is called as the cover-uncover test. So what we do here is we use an occluder or a hand, or we can take something like a sticky note and we occlude one of the patient's eyes and we ask the patient to focus on our nose. And let's wait for 5 to 10 seconds. And then, so let's say if we have it here, I wait 5 to 10 seconds and I'm focusing on the nose. And then I remove the blind. So normally there should be no corrective saccade once the cover is removed. But if you see something like that, that tells you that there is something more going on with this patient. So let's see what an abnormal cover-uncover test looks like. So watch for the right eye. So as you can see that this patient needs to do a corrective saccade to bring the focus back towards the therapist's nose. So let's take a look at another example here. If you focus on the right eye, you see that right eye is deviated laterally once the cover was removed, and the patient needed to readjust the focus. So this is what it will look like, the ones you saw, that there will be a corrective motion of eye to regain focus on patient's nose. So if you see that happening, that means there is a central cause for your patient's symptoms. Another last test that we look into is the convergence, and I'm sure we all have done this at some point during our childhood. So we take a pencil, put it in front of us, we keep looking at it, and then slowly bring it to the nose, bring it to the nose, bring it to the nose, till we are kind of cross-eyed. We have done that a lot since we were children, and mom used to say, don't do it, otherwise your eyes will be stuck like that. So that is something that we know as a convergence testing. So we take the target, we move it towards the nose, and we measure the distance between the target and the nose at a point when the patient tells you, oh, I cannot focus any longer, or I'm starting to see double. So you stop right there, measure that distance between the tip of your nose to that object. So normally a distance of 5 to 10 centimeters, it is acceptable. And if you see this happening, as you see that this eye kind of went rogue, so if you see a lateral deviation of one of the eyes before this distance of 5 to 10 centimeters, that is abnormal, and it is an indicator of central sign. So that is convergence, or in other words, vergence test for you. So that was all about the VOR testing. So to summarize, you did the head thrust testing, you did the smooth pursuits, saccades, and if you find these abnormal, then most likely the problem lies in your peripheral system. But if you find that the cover-uncover test, the convergence test, they are abnormal, that means that there is something central that is going on. So these are a few differentiating features. Oops, why did it stop sharing? So we have a question here that, is it necessary to do an oculomotor test every time we do a vestibular test? I would recommend that. And again, it will depend on how your patient is presenting to you. So if your patient is presenting with, say, an acute exacerbation and you suspect that there is a BPPV, you go ahead and fix that. But it is also a possibility that this patient may have a VOR dysfunction as well. So once the acute problem is resolved, once the BPPV is resolved, I would go ahead and perform the oculomotor testing, because many of the times these patients, they are not able to tolerate a whole lot of testing. So if I see a BPPV, I'll fix it right there. Then I'll call the patient in 2 days, follow up, and then I would do more of a VOR testing. But if I see that BPPV is not an issue here, then I would go ahead and do the VOR testing right on the same day. And that is why it is important to focus on the questions that we ask in history. That will help us direct, because if you see that it's classical BPPV history, you directly go ahead and do that. But I would recommend, and it's a good practice, to do a VOR exam as well, just to ensure that you're not missing out, because majority of the symptoms can be resolved once you're done with BPPV. But if the VOR is an issue, the symptoms will not resolve and they will continue to linger on. So yes, I would recommend doing both of them. Right, so that was all about BPPV and your testing of VOR. Some other tests you'd want to do is Romberg's test, reactive balance, Fukuda's step test, and these are all tests that you would do for partial control. and a modified clinical test of sensory integration and balance, or CTSIB. And I believe we all are familiar with what CTSIB looks like. So we are not going into details of those. And this diagram from Shumway Cook, I believe we all remember that quite well. Right, so along with these testing, folks, it is important that we capture some of the data on subjective pieces. So for that, we use the ABC scale, dizziness handicap inventory, motion sensitivity quotient, and some other measures that we can do for balance include dynamic gait index, functional gait assessment, and the mini-best test. And I believe we are familiar with that. And these, I think these all are free, and you can access them readily online. And I personally prefer the mini-best test. All right, so now what do we do with the VOR issues? So we can divide that into 4 broad buckets: adaptation, habituation, convergence training, and treating bilateral vestibular dysfunction. So adaptation is nothing but the VOR times 1 or times 2 exercises. So what they do is they work on the capability of the vestibular system to make long-term changes in neuronal response to head movement. So I'm sure if you would have come across this a lot. So VOR times 1 is I take an object, I focus my gaze on it, and I slowly try and move my head as much as I can. And then if I'm doing good with this, I will move my head a bit more. So that is VOR times 1. Now, if I move my head and the target in opposite way, that is VOR times 2. And you can also do progression and regression. So if the patient is doing well in sitting position with VOR times 1 and 2, you can do it in standing position, you can do it quickly, you can do it standing on a firm surface and move to the foam surface, unstable surface. You can do it in a brightly lit environment or a dark environment, or you can keep the background busy. You can have a lot of people moving around, or you can have a visual conflict in front of the patient. So there are many ways that you can progress VOR times 1 and VOR times 2 exercises. And you do it for about 30 to 120 seconds, as much as patient can tolerate in each direction. And you do it 3 to 5 times per day. And it can be flexible as much as the patient can tolerate. The next piece is the habituation, and as the name suggests, it is a long-term response to a noxious stimulus. I remember when my mom was yelling at me all the time to study. So after a while, I'm like, yeah, I'll study. So I got habituated. So there was no effect of that stimulus on me. So similarly for vestibular rehab, you subject the patient repeatedly to the position that is provoking their symptoms. And the patients slowly get used to that position and body learns to compensate. And while you're doing this habituation, folks, it is important to understand that you need to tell your patient, oh, you will get worse before you get better. So it is important to know that. Patients should know that the symptoms will increase before they start getting better. And now the question can be asked, how much of an increase is acceptable? So I'll say if we have a 10-pointer scale and the patient is at 3, so if the change is more than 3 or 4 points, if it is going up more than 3 or 4 points, maybe I'll take a step back and slow down on the exercise, or I may think of another alternative. But I would try it for a couple of sessions and see how the patient is responding. And it happens that patients will have exacerbations and they will vomit and all those things might happen. But keep practicing and see how your patient is responding. But if the case is that it is beyond 5 points increase every single time for like 1 week, then I think we may need to take a step back and think of an alternative plan. All right, so last but not the least, and I think we have about 4 minutes left. So Last but not the least is convergence exercises, and there is something called as the Brock string. I would recommend you to look this up. Look up Brock strings, and these are used to train the convergence. And there is some cool thing that I found is known as eye push-ups. So I would recommend you to take a look at this. And Brock strings are now very, very common, and they're used especially in vestibular rehab and exclusively for concussion patients as well. So feel free to explore these two options. And if you have further questions on any of this, you can feel free to follow up with me on my email. So you can have this address. And if you want, you can text me on Twitter, or you can send me an email. And I'll be very happy to answer questions. All right, I think we have a couple of minutes. And we see that for motion sickness also we can do this. Yes, absolutely. We can definitely try this for motion sickness, because if a patient tells you a history of motion sickness, we can say that, oh, we would like to do a VOR evaluation on you. And I'm sure you'll find some issues with VOR. So definitely you can do this with motion sickness. All right. Any other questions, folks?
Yeah, I have a question. Initially, when I was in my college, we started the treatment of BPPV with eye movements and then the neck rotations, and then we went on to the trunk. So is this the same pattern we are supposed to follow, or we have evolved with the treatment to be very particular regarding the canals? And
that's a good question, Anushree. So what I would recommend is, so say, for example, if you do a Hallpike Dix maneuver, right? You find impairments. The test is positive, Hallpike Dix. So I would recommend fixing that BPPV right away and send the patient home that day. Call him back again in 2 days and see how the symptoms are. Follow up on that. And if the patient is able to tolerate then and patient is slightly better, I would suggest doing the VOR testing, because it is quite likely that if it was only BPPV, you can fix it in 1 or 2 visits and the symptoms may never come back. But if you feel that there is an issue going on with VOR, then I will go ahead and get started with the VOR times 1 or times 2. But if it is only BPPV, I would not go with VOR 1 or VOR 2 exercises, because that is not needed in that case. Did that help, Anushree?
yes. Thanks.
Absolutely. So let me come back to a question that was raised earlier. And this is something that is open for discussion. There's a very interesting scenario that is presented to us. So I would love your inputs on this. If a patient who's 65-year-old complains of unsteadiness and disequilibrium, has history of falls, he's a diabetic and hypertensive, and he also complains of dizziness and vomiting, and symptoms are exaggerated unilaterally on left side. So what do we think is going on with this patient? So patient is having dizziness, nausea, vomiting, and unilateral symptoms. How do we want to proceed here? What is everybody's thoughts? Yes, we would do a C-spine. Okay. And symptoms are unilateral, so we'll ask questions related to is he having tinnitus, difficulty in hearing, fullness in ears, and so on and so forth. If we don't have that issue, then we would look for symptom duration. Is it lasting for seconds or minutes? If it is seconds, we may think for a BPPV. That may be going on. Absolutely. So unilateral can direct us to either BPPV, or if the person has associated symptoms like difficulty in hearing, hearing loss, or tinnitus, fullness in the ear, that is directing us to other causes that could include, say, labyrinthitis or vestibular neuritis, and maybe you can say dehiscence and so on and so forth. And this is where I would want to refer this patient out to a doctor if you see all these causes associated. And please feel free to follow up with me later on the email for this. I'll be very happy to talk and further work with you on this. And thank you so much, everybody, for being here. It was great having some good discussion with all of you, and I look forward to some further collaborations down the line. So well done, everybody. Great job. And have a wonderful rest of your day.
So thank you all of you, everyone who could attend this session, and everyone who was there for this session. It was very nice having all of you. I'm glad you guys could take out time for a 2 hour session, and you guys attended the session. We are very happy, and definitely if it helps you at all, already Dr. Ashutosh, Dr. Devashish has already shared his email ID with you guys, his Twitter handle account as well. So whenever you have any doubts, whenever you go through the lecture and you realize you have some doubts, you can always mail Dr. Tiwari. You can always post a question on Twitter, and definitely we would like to have all of your feedbacks on this session. So I would like to thank all of you for your time, the time which you could give to us, the time you could complete this session. We are very happy to see this sort of participation. And whenever you see this session on YouTube, whenever you see this session later, do make sure you ask your questions and post your questions to email ID which Dr. Devashish has already shared with you. Thank you guys. It was very nice having all of you. And definitely please like, share, subscribe to our channel for many such lectures and many such content which we are going to present sooner or later. Thank you. It was very nice having all of you. Thank you for your time.